Hello everybody, my name is Dr. Amir Sandhu and welcome to another episode of Physiology Made Easy. Now in today's episode we're going to talk about the acute cardiovascular responses to exercise. So in terms of the knowledge that you need to have before you look at the rest of the presentation, you should be familiar with the anatomy of the heart and the blood vessels and also the role that the autonomic nervous system makes in regulating our heart rate and also in terms of vasoconstriction as well. So how we have dilation and constriction in various parts of the body. It would also be useful to know about the energetics of exercise, particularly through aerobic pathways, and also just have a basic understanding of pressure gradients, of how blood will move from areas of high pressure to low pressure, and how that relates to blood flow going to the tissues from the heart. So moving on in terms of the learning outcomes, what I would expect you to take away at the end of this presentation is to be able to confidently summarize the main changes that occur when we start aerobic exercise in the cardiovascular system. So these are the initial changes that happen, and also to appreciate or understand the integration of several different physiological systems in the body, including the autonomic nervous system, the concept of venous return and how that inputs how that relates to cardiac output, and also the role of the central and local muscle receptors and how they influence activity in the brain, and also how they input or influence cardiovascular function during exercise. So I want you to do a task before you continue the rest of this presentation. So after I've stopped speaking, you can pause the video. What I want you to do is just to get up, run on the spot for 60 seconds, get yourself warm, and then I want you to sprint hard on the spot for 30 seconds. Try and do it as fast as you can, okay? So you can hit the pause button and do this. So hopefully you've done it. You're going to be breathing quite heavy. Grab a glass of water and get yourself settled again. So what I really wanted you to do with that task was actually to think about the physiological sensations that you just felt. So what happened to your heart rate, what happened to your temperature, what happened to your blood pressure. So those kind of feelings that you experience, that is essentially the cardiovascular response. And what we're going to do now is break down exactly what happened as you started to do this exercise. So essentially, what you've just had is a classic cardiovascular response. As soon as you start to exercise, or even before exercise, we start to get some changes in our cardiovascular system. Now, how that happens is we have the primary motor cortex, which is located in the medulla oblongata, which is in the vasomotor center. So the vasomotor center is in the medulla oblongata. We've got the motor cortex, and that's going to initiate some responses to via several nerves to the heart and to the blood vessels. So the first thing that would have happened is via efferent pathways. So by efferent we mean that it has an effect. So there is a target tissue that is going to have an effect. So the brain has been primed already before you even move a muscle that you're about to exercise. So there'll be an anticipatory rise in heart rate. So that will happen even before you start to make any movement. So you'll start to get that adrenaline. For me, it happens when I'm about to go for a run. As I'm tying my shoelaces, I start to feel the adrenaline, the butterflies in the stomach, and my heart rate starts to increase. And of course, the importance of all of those responses is that once your heart rate is increasing, then your body is trying to adjust in the sense that it wants to get more blood flow going to those working muscles, i.e. the quadriceps and hamstrings in this running example. You're also going to have increased inotropy. Now, inotropy basically is the contractile force of the heart, okay? So it's how strong or how forceful the contraction of the ventricles are to eject blood to the rest of the body, particularly the tissues. So what's going to happen is when you start to get this increased autonomic nervous system activity, get the increase of noradrenaline, that's going to bind to beta-2 adrenergic receptors in the heart. It's going to cause an increase in contractile force. That's going to lead to an increase in stroke volume, which I've abbreviated as SV here. And when you have increased stroke volume, you increase blood pressure and perfusion pressure. So you've got more blood going to the tissue. Okay, that's extremely important. That's one of the main reasons why you have this increase in contractility. Now, at the same time, you have mass sympathetic nervous system discharge. So the sympathetic nervous system kicks in shortly before we start exercise, but it's certainly into full swing once we're actually making the movement. And essentially what the sympathetic nervous system discharge does is it causes vasoconstriction of most of the blood vessels in our body. There is some evidence that in the working muscles there will be vasodilation to allow blood flow to get to that tissue and provide oxygen, remove waste products. But certainly for example, in the gastrointestinal tract, in the kidneys and in the other abdominal organs that do not need blood flow during exercise, there will be vasoconstriction. And in fact, there is vasoconstriction in non-active muscles as well. So those muscles that you're not using for a particular movement will have vasoconstriction. And that increases the systemic vascular resistance. Okay, so you have this increase in systemic vascular resistance, we get an increase in blood pressure, we get blood redistributed to where it needs to go, so i.e. the working muscles, and that blood is then obviously taken away from areas that it's not needed. And equally we get vasoconstriction as well. Now that increases venous return, and it's very important at this point because our veins hold about 60 to 75% of our blood. Okay, so most of the blood is held in our veins. That's why they're known as capacitance vessels. They're like reservoirs for the blood. And when you have constriction of the veins, then like you squeeze a tube of toothpaste, the blood will then return back to the right atrium much more quickly, and then that will obviously increase preload, which we're going to talk about in a short moment, and increase more the amount of blood going back out through the left ventricle. Okay, so if we can get more blood returning back to the heart by squeezing the venous system, we're going to get more blood going out to the tissues where it's needed. So the skeletal and respiratory muscle pump also helps venous return, and this is like a mechanical aspect of the cardiovascular system. Okay, so there's a mechanical action, and I'll explain what I mean by that. Now, in our calf muscles, we've got veins that are interspersed between the muscles, between the gastrocnemius, and essentially when we're making a movement, when we're contracting that muscle, it's actually squeezing the veins. And because the veins in the lower limbs will actually have blood that needs to be returned back to the heart against gravity, it needs a little bit of help to be propelled or to be pushed through back to the right atrium. Okay, and obviously we know that veins have valves, so that the valves prevent backflow of blood. So as blood passes through them, the valves will close, and the muscle action will cause the squeezing of those veins, and that will increase venous return. Now, I mentioned the term earlier, and that term is called preload. Preload is basically the amount of stretch of the cardiomyocytes, and the cardiomyocytes in the heart will stretch if there is more blood filling into the atria and into the ventricles. So the greater the filling and the greater the return of blood to the heart, then there will be greater preload, and that will mean that there will be a stronger contraction, and this all happens via the Frank-Starling mechanism, which we'll talk in more detail about in a short while. There is also another pump, the abdominothoracic pump or respiratory pump, which draws blood in from the inferior and superior vena cava, and again we're going to go into the details about how it actually does that. So there's two specific pumps that help with venous return. There's also a central response from the muscles. So we know that the muscles have a number of receptors. The metaboreceptors are actually muscle-specific receptors. We also have chemoreceptors throughout the body, and what they're doing is detecting changes in blood gases. Okay, so carbon dioxide, which is increased when we start aerobic exercise, and oxygen levels, which is decreased because the tissues are consuming it to produce ATP or energy. So these receptors are detecting changes in these blood gases and sending a signal back to the vasomotor center in the medulla. Okay, we also have mechanoreceptors. and they're detecting changes in the muscle itself. So we've got muscle spindles, okay, so we've got the fibers in the central belly of the muscle, which are detecting stretch and movement, and they're sending signals. There are proprioceptors sending signals back to the brain, and also skin receptors are detecting stretch and movement and deformation of the skin. That information is going back to the body. We've got thermoreceptors, because as we start to exercise, we start to use more energy. Byproduct of energy is heat production. The thermoreceptors are able to detect that, send information to the brain. And as an aside to that, one of the things the brain is then able to do is, obviously then you will start to have the onset of sweating, and you'll have movement of the blood, or shunting of the blood towards the skin, where you've got the skin blood vessels, along with the sweat. The blood flowing through the kind of skin blood vessels will allow evaporation of that heat. Okay, so that's one of the ways that the thermoreceptors will work. And of course, what we mean by an afferent pathway is that this is a sensory signal being sent to the brain. So an efferent pathway is an effector signal. So the brain is telling a tissue or a particular part of the physiological system to do this, whereas an afferent pathway is like a sensor, and it's sensing the environmental changes or the homeostatic changes within the body. We also have local responses within the muscle. So as soon as you start to exercise, one of the first things that will happen is you'll start to produce metabolites, because you're going to have this metabolic process that's taking place. You're going to have the production of adenosine, lactate. There'll be an increase in potassium ions, hydrogen ions, adenosine diphosphate, which is the used form of ATP. So once a phosphate has broken off to provide energy, you're left with ADP, and you've got carbon dioxide buildup as well. What these do is they stimulate what we call metabolic vasodilatation. So the blood vessels in the quadriceps muscle here, or any other muscle that's being used whilst you're exercising, will start to have dilation. It's the microvessels, the capillaries, which will start to dilate and increase perfusion, increase oxygen to the tissue, remove these metabolites as well. And one of the other good things about the local metabolic response is that it reduces the systemic vascular resistance. So you have this increased perfusion and reduction in systemic vascular resistance. It helps also to regulate blood pressure as well during exercise. So these are the main mechanisms. When you start exercising, these are the acute changes in the cardiovascular system when you start aerobic exercise. And what we're going to do through the rest of the presentation is go through each one of these and explain them in detail, so that you have a very good understanding of each of these. And remember, the information is relevant for your understanding, so that you can help in your own training, you can help athletes that you might work with, and also to help patients as well that might be starting exercise rehabilitation programs. So one of the first things that happens, as we've said, is that the cardiovascular center, or the vasomotor center in the medulla, is activated, and what that essentially does is it then makes an effector response. Now, first thing that's happening is you're having these afferent signals, these inputs to the cardiovascular center. So we've talked about we've talked about the receptors. Proprioceptors, baroreceptors are also pressure receptors that detect stretch, and they're located at various strategic points in the cardiovascular system. And chemoreceptors as well, we've talked about. But you've also got, obviously, receptors that are involved in movement, emotion, so the limbic system, which is involved in emotion, and this is why it's extremely important for a number of sports to be able to control your emotions, so that you can focus all of your energies on making sure that you have an efficient cardiovascular response. That is to deliver blood to the tissues as quickly as possible and get rid of the metabolites as quickly as possible, so that you can really get yourself into peak performance. So you have these inputs going to the cardiovascular center, and then the cardiovascular center via various nerves. So with the parasympathetic system, it has the vagus nerve, and that innervates the heart and some other areas. The vagus nerve is active at rest. Whilst you're listening to this presentation, your sinoatrial node, atrioventricular nodes are being innervated by the vagus nerve. It's keeping your heart rate at a resting level. Now, once you start exercising, you'll have accelerator nerves that are on the sympathetic branch of the autonomic nervous system, and they will increase your heart rate and your contractility, as we talked about before. And nerves going to the blood vessels will cause vasoconstriction, and we talked about that as well, relating to the mass sympathetic nervous system discharge. So that's what's happening in the cardiovascular center. In terms of how the heart rate is controlled, because this is one of the major things that you will notice when you start exercising, your heart rate will start to increase. How and why does that happen? Well, let's first talk about what happens in terms of keeping your heart rate low. So the vagus nerve, or also known as the cranial nerve X, is located or is part of the cardio-inhibitory center, okay? And what it will actually do is inhibit the sinoatrial node and the atrioventricular node, and it extends the time for repolarization. Now, anybody that is not familiar with that term, what I'm referring to here is that action potentials or electrical impulses that cause changes at the sinoatrial node are due to ionic changes in sodium and potassium, okay? And we call those changes in the membrane potential action potentials. It's beyond the scope of this video to discuss that, but I would suggest for you to read up about action potentials to increase your knowledge. So the vagus nerve, what happens is by extending the repolarization time, you slow the rate of depolarization. So you have less action potentials, and that will reduce the contraction of the myocardium, and therefore your heart rate will reduce as well, and that's what will happen at rest. Now, if I was to take my heart out and put it onto a table, it would carry on beating for about 100 beats per minute, because the sinoatrial node is the pacemaker of the heart, and its intrinsic rhythm is around 100 beats per minute. So it's these nerves that help to keep the heart rate below 100, and equally, once we start exercising, then the cardiac accelerator nerves will activate, and they'll innervate the sinoatrial and atrioventricular node. They'll also innervate the atria and ventricle, some of the other parts as well, and they will do the opposite of the inhibitory nerve. So what is the opposite? The opposite is to shorten the time of the repolarization period, so that you have a quicker rate of depolarization, more action potentials firing through to the nodes, and therefore what you will actually have is increased heart rate and increased contractility. We also have the sympathetic nervous system releasing noradrenaline or norepinephrine, depending on which textbook you read. So noradrenaline, norepinephrine will bind to beta-1 receptors. Now, at the start of the presentation, I erroneously said beta-2 adrenergic receptors, but it's beta-1 receptors, and they will increase heart rate and inotropy, contractility. Okay, so that's how we're controlling heart rate. That's how the brain, via the autonomic nervous system, is controlling heart rate. Now, in recent, basically in the past, it was believed that when you begin to exercise, what happens in terms of your increase in heart rate is that at about 100 beats per minute, you have a withdrawal of the parasympathetic nervous system activity, so your heart rate starts to increase, because remember, the parasympathetic nervous system activity is the brake, and the sympathetic nervous system activity increases. And that's what was believed in the past, and indeed I was teaching that to my students some years ago. But in 2014 there was a paper released by White and Raven, fantastic paper, very comprehensive, about how heart rate is regulated during exercise by the autonomic nervous system. And what they actually showed was from the evidence, from a large body of evidence, is that the parasympathetic nervous system continues to be activated well into aerobic exercise. So it doesn't just drop off at 100 beats per minute and then the sympathetic nervous system takes over. No, what happens is the parasympathetic nervous system activity kind of starts to reduce its effects on the sinoatrial and atrioventricular node to about 140 beats per minute. And equally at the same time, sympathetic nervous system activity is also increasing, and we start to see this increase in sympathetic nervous system activity and intersecting at 140 beats per minute is where they're both making an equal contribution to the increase in heart rate. So the parasympathetic nervous systems hold on the atrioventricular and the AV and the SA node is reducing, and the sympathetic nervous system's activity has kind of reached to the point where they're both intersecting, is increasing the heart rate. And then beyond this point, it's the sympathetic nervous system which contributes to further increases in heart rate. Okay, so this is how we have the contribution of those two branches of the autonomic nervous system to heart rate. Now, the autonomic nervous system is also important in regulating blood flow. So I mentioned earlier about how blood is redistributed to areas where it's needed, away from areas where it's not needed. So at rest, what we have is blood flow to the kidney and the abdominal organs is quite a lot higher than when it is at exercise. Obviously, blood to the skeletal muscles isn't very high, because if you're resting, you don't need blood going to the skeletal muscles. As soon as you start to exercise, what you actually start to see is an increase in blood flow going to the skeletal muscle. So you can see quite a large increase in skeletal muscle blood flow, and conversely here in the red you see a reduction in all of the blood going to the abdominal organs. So there's vasoconstriction of the vessels here, vasodilation of the vessels here. Some of that vasodilation is mediated by the sympathetic nervous system. Much of it is mediated by the local response of the muscle, i.e. the metabolic vasodilation. So you have this increased blood flow going to where it's needed. We also have a big increase in skin blood flow, because as we exercise, we're producing heat from the energy metabolism. So we're sweating. You want to get that blood shunted to the skin so that the heat can evaporate through the sweating. So that's another thing that we're seeing. The myocardial blood flow also increases because the heart is pumping harder. So it's contracting more, it's contracting harder, it's contracting more frequently. So therefore the coronary circulation also has an increase in blood flow. And of course, if you're a individual that has myocardial ischemia, or you've got cardiovascular disease, then essentially what would happen in this situation is, whilst the heart is working harder, if those coronary blood vessels are furred up with atherosclerosis and narrowed, then you're going to start to get pain. So that's how myocardial ischemia occurs, because the coronary vessels won't be able to get that increased blood flow to the myocardium when it's working hard during exercise. And just a quick note about brain blood flow. So brain blood flow also increases up to about 60% of VO2 max, and essentially at that point, at 60% VO2 max, you're producing lots of CO2, lots of hydrogen, and the hydrogen causes vasodilation of the cerebral blood vessels, and that obviously then increases the blood flow to the brain. Now, above 60% VO2 max, the research evidence shows that you start to hyperventilate in a greater degree, so you blow off a lot of that CO2, and therefore you don't have the buildup of those metabolites, and so therefore the brain blood flow, you get less vasodilatation, less cerebral blood flow. So skeletal muscle pump and preload, again, this is quite a simple concept really. The idea is that you've got your gastrocnemius muscle, your calf muscle, squeezing the veins to get blood against gravity back to the heart. The more blood you can get back to the heart, the greater the preload, which is the stretch of the myocardium. And also, one of the things that happens is, as I mentioned before, you've got these valves and they close to prevent backflow of blood. Now, the reason I've got a plane on there is that when we make air travel and we sit down for a long time on a long flight, then you'll get pooling of blood. Because you're not moving the muscle, you're not using this mechanical mechanism to get blood back to the heart. So you get pooling, and there's an increased risk of thrombosis, or deep vein thrombosis as we call it, and it can be quite severe and sometimes fatal condition. Now, you can wear compression socks, and the idea of compression socks is to try and squeeze the muscle to try and get blood flow going, to increase venous return, getting blood flow back towards the heart. So that's just a point related to that. Now, we also have a respiratory pump as well, known as the abdominothoracic pump, and this looks quite complicated, but it's quite straightforward. So some abbreviations that we've got, this abbreviation here is the intrapleural pressure. We can see here, this is the pressure within the pleural space, the thoracic space. SVC, superior vena cava, it's the vein that brings blood from from the upper extremities, and the inferior vena cava brings blood from the lower extremities back towards the heart. And this is the heart, the right atrium, the right ventricle. Okay, now essentially, let's talk through this diagram. What happens is when we inhale, so if I inhale now, what you've actually seen is my chest has expanded, my diaphragm has actually flattened, and I've increased my thoracic space. Now that increase in volume has dropped the intrapleural pressure. So as soon as I've inspired, the intrapleural pressure is now dropping. Okay, and we can see the red arrows here represent the increase in volume. Now, as the interpleural pressure drops, then what happens is the right atrium, the right ventricle, the inferior and superior vena cava can expand. They've got the space and the drop in pressure to expand and increase in size. Okay, and we can see again these red arrows here, the veins and the ventricles, atria, increasing in their size. Now, when you increase the volume of something, you further drop the pressure. So imagine you've got blood coming from, you know, the upper extremities, the lower extremities. It's under high pressure, and here, and then when it gets to this portion here in your thoracic space, the structures have enlarged, so the pressures here are lower. Blood will always move from high pressure to low pressure. So it's almost like sucking the blood in or drawing the blood in. So every time we inhale, we're increasing our venous return, okay? And conversely, as we start to, and we can see that here, inspiration, dropping the pressures, dropping the pressure in the right atrium, increased venous return. And the opposite happens when we expire, okay? So that is essentially what's happening. Another important point is that when we do inhale, so and my diaphragm is now flattened, it squeezes all of the abdominal vessels, and it squeezes every last bit of blood out of them to return it back through these veins to the heart. And by that method, we can increase venous return. And it's a fantastic physiological method, because when you exercise, the respiratory response dictates that you're going to breathe rapidly and hard. So each time if you're going for a run and you're breathing deeply, this mechanism is actually contributing to increasing venous return, which means greater cardiac output, blood to the tissues. Now, the Frank-Starling mechanism is basically relating to the fact that the force of a contraction of the myocardium is related to the initial length of the muscle fiber. Okay, now the cardiomyocytes are basically like any muscle fiber. They've got actin and myosin proteins which involve connecting, forming a cross bridge, and contracting and making that contraction. Okay, so the idea of the Frank-Starling mechanism is that you increase venous return, which increases preload. So you've got your skeletal and respiratory pumps, you've got venoconstriction, you've got more blood going to the heart. That bit's fine. Then, and if I get my elastic band, what you do is imagine this is the left ventricle here. Okay, as we've got this increased blood going back to the heart, the wall of the myocardium of the ventricle is stretching. Now, when it's stretching, it's going to have a more energy, and it's also going to have a greater force of contraction. Now, how that happens is imagine the cardiomyocytes in the left ventricle expanding as the blood is filling. The actin and myosin are going to kind of have a stretch to what we call an optimum length for actin-myosin crossbridge formation. So they're going to be optimally stretched. So when the actin and myosin crossbridge formation happens, and we have this contraction or shortening of the sarcomeres, then you're going to get a very strong contraction. Okay, so that is the idea of increasing preload, because but what you do is you increase the end diastolic volume, which is the amount of blood that's left in the heart at the end of the filling phase, the diastole. And so you've got this optimum stretch of the cardiomyocytes, increased preload, that's going to increase contractility, inotropy. You're going to get greater stroke volume. Combine that with the changes in heart rate that occur from the autonomic nervous system, and your cardiac output, which is abbreviated as a Q, normally with a dot, but I couldn't get the Q with the dot. So your cardiac output will increase. And let's just take a look at what this means in terms of a graphical representation. So at rest, what happens is you have about 130 ml of blood that remains in your ventricle at the end of diastole, at the end of the filling phase. And that equates to about 70 milliliters of stroke volume. So when your heart contracts at rest, it pumps out about 70 ml of blood. As soon as we start exercising, your end diastolic volume is actually going to increase to 210 ml. So you're going to have more filling. The more filling is going to happen through these mechanisms that we've talked about here. And that's going to translate to about 110 mils of stroke volume. So the amount of blood that's pumped out to the body. That's quite a large difference. So you can see that the Frank-Starling mechanism, this idea of filling the blood, filling the heart with more blood, get optimum stretch, stronger contraction, relate to heart rate, you're going to increase your cardiac output. Hopefully that makes sense. It is quite straightforward to understand. I want to move on then in terms of what happens in the muscle, and I've got an example here of a boxer. So this is a very cardiovascular sport, one of the most toughest sports in the world. Essentially what happens with a boxer, as he goes out into the first couple of rounds and he's throwing his punches, the energy usage in the muscle is obviously going to be quite high. That's going to produce metabolites. And those metabolites are known as adenosine. It's going to carbon dioxide from the energy metabolism, lactic acid, hydrogen ions, ADP, and a whole host of others. These will cause what we call metabolic vasodilation, and the capillaries in the muscles will increase in their diameter, and that will allow greater perfusion of the muscle. So we can see that at rest, most of the capillaries are closed, okay, because you don't really need that much blood flow going through. As soon as you start exercising, so he's throwing his punches, he's a third of a way into the round, the capillaries are open. And that's allowing that perfusion to take place, oxygen to be delivered to the tissues, CO2, hydrogen, these other metabolites to be taken away. And also the capillaries have a very large surface area to the sarcolemma, to the part of the muscle. So they're kind of innervating each of the myofibrils, and they have a very good large surface area. The capillaries are one cell thick, so they allow easier gaseous exchange too. This happens very quickly, so within a few seconds of starting physical activity. So those vascular changes, they're not taking a long time, they're happening quite sudden, and the magnitude of those changes will depend on the intensity of the activity. So just moving on then to a concept called arterial mixed venous oxygen difference. This basically tells us how much extraction of oxygen the tissue is making, and it's relative to the intensity of the exercise. So at rest, what you would have is about 20 mils of oxygen per 100 ml of blood. Okay, so if we were to measure the oxygen levels in arterial blood, 100 mils of arterial blood would see about 20 mils of oxygen. If we were to then take a measurement at the vein, we'd see about 15 to 16 mils of oxygen per that same quantity of blood. And that the arterial venous difference, so the difference in oxygen in the artery and the vein, is about 5 mil. That's not such heavy usage. Okay, so most of the oxygen that entered into the capillary with the hemoglobin is still attached to the hemoglobin as it goes back to the vein. As soon as we start intense aerobic exercise of the whole body, we will start to see a greater arterial venous oxygen difference. Now what that means is the capillaries or the tissues are requiring or using much more oxygen. So the hemoglobin is unloading more of its oxygen to the tissue, so a lot more oxygen has been used. So in the end, if we take a venous blood sample, we will actually see that there's much less oxygen remaining in that venous blood sample. So most of it's been unloaded to the tissue. So that's what happens with intense exercise. When you do really intense aerobic exercise, and then what's happening in the muscle. So this is, at very high intensities, you're going to get very large differences in the arteriovenous concentrations of oxygen, okay, or amounts. So what will happen here is that you'll only, in very intense exercise, the tissue is going to be using a lot more oxygen. So therefore, if we were to take this example here, if the tissue was using 18 mil of oxygen per 100 mil of blood, then what would happen is in that 100 mil blood that we measure at the venous end, we'd only have very little oxygen left. So by performing these measurements, we can actually determine the amount of oxygen that might be used in a tissue, the oxygen consumption. Okay, now what's important is, with this point that I want to make here, is that this illustrates that the muscle or the tissues are very efficient at extracting oxygen. They can get every last ounce of oxygen out of the hemoglobin if they need to. So that the extraction of oxygen is not a limiting factor for aerobic performance. So fatigue, when you have to stop after very intense exercise, is not due to inadequate extraction of oxygen. It's usually that you can't get enough blood flow going to the capillary. It's usually cardiac output and the supply, which is a limiting factor for fatigue and aerobic fitness. So the Fick equation can be used to look at the relationship between aerobic metabolism and the cardiorespiratory system. So it looks at the rate of oxygen. So just what we've talked about, it was developed by Adolf Fick in the 1870s. So it's an equation that's been around for a long time, and it can be calculated in two ways. So oxygen consumption, which is VO2, it is cardiac output, which is heart rate times stroke volume. And then you times that by the arteriovenous oxygen difference. So once you've done this calculation, it will give you a measure of how much oxygen is being consumed. Okay, so it'll give you a measure of oxygen consumption. And this is quite commonly an equation that you want to be familiar about if you're doing aerobic fitness testing in a laboratory. So to summarize today's presentation, what we've actually talked about is everything on this slide. We've talked about the fact that we have a cardiovascular control center located in the medulla, which receives inputs from several different factors. So receptors within the muscle, the motor cortex in the brain, activation of various receptors like the baroreceptors and the chemoreceptors, and then it then elicits an effector response. That effector response could be venoconstriction to increase preload, get more blood by getting more blood back to the heart, increase contractility by acting on beta-1 receptors of the heart, so noradrenaline release, increasing heart rate as well, and also causing vasodilation in active muscles, but vasoconstriction in non-active muscles. Okay, and essentially we also talked about the muscle and respiratory pump, which independently of what's happening in the brain, mechanically increase cardiac preload. So the squeezing of the muscles by the calf muscles, squeezing of the veins by the calf muscles, and also the respiratory pump change in thoracic volume, drawing blood into the right atrium, they increase cardiac preload. That will lead to an increase in stroke volume. Along with some of the other changes, you'll have an increase in cardiac output. That will increase blood pressure, and blood pressure is extremely important for the perfusion of our tissues during exercise. So there you have it. These are the main changes that happen in the cardiovascular system when you perform aerobic exercise. Stay tuned for more videos. We'll be going through some of the respiratory responses that happen during exercise. So I'll hopefully see you soon.